Hi, I'm Peter Voorhees. I'm a myeloma physician at the Levine Cancer Institute in Charlotte, North Carolina. I'm here in Orlando, Florida at ASH 2019, and I'm going to be discussing the results, the updated results of our Griffin trial, the randomized phase 2 study evaluating the addition of Daratumumab into the backbone of Lenalidomide, Bortezomib, and Dexamethasone, or RVd, for transplant-eligible newly diagnosed myeloma patients. So, as we all know, RVd induction therapy has become the standard of care, not only in the United States, but in many other countries as well, for the treatment of newly diagnosed multiple myeloma patients, whether they're going to undergo autologous stem cell transplant as consolidation therapy or not. We know that Daratumumab, which is a CD38 monoclonal antibody, when added to Lenalidomide and Dexamethasone, improves depth of response and progression-free survival for not only relapsed patients, but newly diagnosed patients as well. Similarly, we know that the addition of Daratumumab to Bortezomib-based therapy, both in the relapse setting as well as in the newly diagnosed setting, improves depth of response and progression-free survival. So it's only logical that the addition of Daratumumab to the RVd backbone would similarly have the potential to improve depth of response compared to RVd alone, and thereby improve the durability of those remissions. So the Griffin trial was a phase 2 study which initially had a 16-patient safety run-in that we presented at ASH last year in 2018. And what we showed in those first 16 patients is that the 4-drug combination of Daratumumab with RVd was well tolerated. The side effect profile in those patients was as expected. There were no safety signals with regards to stem cell collection and mobilization, and there were no issues with regards to neutrophil and platelet engraftment. And just as importantly, or more importantly, the preliminary efficacy signal was quite strong, with the vast majority of the patients achieving stringent complete response. So we then went on to the randomized phase 2 portion of the study. Patients in the control arm, those that were not receiving Daratumumab, got 4 3-week cycles of induction RVd chemotherapy. They then underwent stem cell collection utilizing G-CSF with or without the addition of plerixafor. They then went on to a melphalan 200 autologous stem cell transplant. After recovery, they received 2 3-week cycles of RVd consolidation therapy and subsequent lenalidomide maintenance therapy until disease progression or unacceptable side effects. In the Daratumumab arm of the study, the backbone was exactly the same. The only difference was that Daratumumab was given during the induction phase for all 4 cycles weekly. When consolidation started up after transplant, patients received Daratumumab on day 1, and then during maintenance, which was 4-week cycles, Daratumumab was administered on a once every 4-week basis. And the Daratumumab was continued for 2 years, but patients again were encouraged to stay on lenalidomide maintenance until disease progression or the emergence of unacceptable side effects. Now, progression-free survival in newly diagnosed myeloma patients has gotten dramatically better with the advent of the IMiDs, the proteasome inhibitors, and the antibodies. So there's a very pressing need for surrogate endpoints that read out earlier that can predict longitudinal outcomes of progression-free and overall survival. And in that regard, the primary endpoint of the Griffin study was achievement of stringent complete response by the end of consolidation therapy after transplant. We know that minimal residual disease, or MRD testing, is also a very important marker of depth of response. So we looked at MRD as a secondary endpoint, other clinical efficacy parameters such as progression-free and overall survival, and just as importantly, safety. So when we presented the initial readout of this data set at IMW in Boston in September, what I showed everybody is that by the end of consolidation therapy, the rate of stringent complete response in the Daratumumab arm of the study was 42.4%, which was an improvement compared with 32% for those in the control arm, with longer follow-up. So at that time, median follow-up was 13.5 months. At the time of this data cut, median follow-up was 22.1 months. And I'm happy to say that depth of response continues to improve for patients in both arms, but there remains a superiority to the DARA arm. So at the time of the specific data cut, the stringent complete response rate in the DARA arm is approximately 63%. in contrast to 45% for those on the RVd arm. When you look at all complete responses, both stringent and non-stringent, about 80% for those receiving Daratumumab, in contrast to 60% for those in the control arm. We did also look at MRD testing, as I mentioned before. The MRD negativity was read at a sensitivity of 10 to the minus 5, and we used Adaptive's next generation sequencing platform. And the MRD negative rate in the Daratumumab arm was approximately 50%, and it was 20% for those patients in the RVd arm of the study. So we've started to look at progression-free and overall survival, and I'm happy to report that both groups of patients are doing very well. So at 2 years, the progression-free survival in the DARA arm is approximately 96%, and it's close to 90% for those in the RVd arm. And when we look at overall survival at 2 years, it's approximately 96% in the Daratumumab arm, and it's about 93% in the control arm. So both groups of patients are doing quite well. As far as side effects are concerned, nothing unexpected. So there was more neutropenia with the inclusion of Daratumumab into the RVd backbone. We also saw somewhat increased rates of thrombocytopenia or low platelets. We did see a clear signal for an increased rate of overall infections. So if you look at infections of all grades, that occurred in 91% of the patients in the DARA arm. Now realize median follow-up is close to 2 years. It was 60% for those in the control arm. However, when you look at severe infections, grade 3 and higher, the rate was the same in both arms at 22 and 23%. When you look at mobilization, the median number of CD34 cells per kilo that were collected were virtually identical between the two arms. However, we did have to use more plerixafor in the DARA arm relative to the control arm. It was about 70% of patients in the DARA arm that also had plerixafor with their G-CSF, in contrast to 55% for those that were in the control arm. When you look at median time to neutrophil and platelet engraftment, it was essentially the same. So, I would conclude, that the addition of Daratumumab to the RVd backbone in a transplant setting clearly improves depth of response, as, read out by stringent complete response, as well as MRD negativity. We are seeing unprecedented progression-free survival with both arms, which is absolutely terrific. And I think it'll be important to see how this study evolves over the course of time, whether this increased rate of MRD negativity in the DARA arm will translate into an increased rate of sustained MRD negativity 1 and 2 years into maintenance therapy. And it'll be interesting to see how the progression-free survival evolves over the course of time. I will mention that there is a phase 3 study in Europe called the Perseus trial, which has actually finished enrolling patients. Very similar construct to the Griffin study. The difference is it's a larger phase 3 study, and it's powered to detect a difference in progression-free survival.